Okay, brilliant. Okay, so let me make sure that we are live on Facebook. Okay, folks, we are live, and what you all can. All right. Okay. So, welcome to the Progressive Mind Show, ladies and gentlemen. How are you all doing today?
We're doing good.
Excellent. Excellent. We so want to welcome all listeners and audience to the Progressive Mind Show. Today is the 6th of May, 2020. Yesterday was Cinco de Mayo, but of course, nobody even heard about it. For folks who live in Chicago, nobody kind of remembered it because it just, because of what we're dealing with. So happy Cinco de Mayo to everybody who celebrates it, to our fellow folks, fellow neighbors in the the Latina community. Once again, you are all welcome. If you just joined us, this is the Progressive My Show. I'm your host, Alinko, and you can share the feed so your friends and us can all, your friends and my friends can all benefit from the discussion this evening. You would see a notification bell by the Progressive. Once you like it, you will see the notification button. Please hit on that. So each time we come on air, you can join us. The Progressive Mind is about promoting our community, building our community. And so day in, day out, week in, week out, we bring in conversations that would help achieve this goal. Today, we have great guests. The third one is trying to come on due to, technical glitches. We're trying to get John Oben to join the feed. But this evening, we have Dr. Mcgee, Dr. Michael Mcgee, who is the CEO and president of the Premier Urgent Care right here in Hyde Park. Also with him is Dr. Bertha Serwa, who's going to be helping us. But I'll start with the lady first. In terms of her credentials, Dr. Bertha Serwa IE is, of course, a medical doctor. She's also a fellow of the American College of Physicians. She's also a fellow of the Infectious Disease Society of America. She holds a master's degree, master's in business administration, which is an MBA degree. She is she's an adjunct assistant professor and of the assistant professor of the Kansas Health Medical Center, USA. She also lectures as an adjunct lecturer at the University of Development Studies in Tamale, Ghana, and the University of Health and Science, Allied Science in Ho, Ghana. She's also a board-certified infectious disease specialist and fellow of the organizations that I just mentioned earlier. Currently, she is the vice president of the Ghana Physicians and Surgeons Foundations North America. This lady has a lot of accolades, but because of time, we may not be able to go into all of it. Welcome to the show, Dr. Aye.
Thank you. Thank you very much.
You're welcome. And so next to Dr. Aye is Dr. Michael Mcgee, who I said earlier, he is the president and CEO of the Premier Urgent Care Center. I think it's the only urgent care center here in Hyde Park. He will tell us more about it. He's a caring and passionate emergency physician who has been practicing emergency medicine for since 2014. He got his bachelor's of science degree in biology and psychology from the Purdue University. He also has public health, a master's in public health administration, master's in public health with a focus in epidemiology and biostatistics from UIC. He attained his medical doctorate degree from Rush University and completed his internship and residency at the Emergency Department of New York University, which is the specifically Bellevue Hospital Medical Center. He also once volunteered as a ringside physician for the New York Police Department fundraiser. This man is a member of the American Medical Association, National Medical Association, Cook County Physicians Association, and has a brown belt in Shotokan Karate. So he's not only a smart man, don't mess with him because he has a brown belt in Shotokan. Ladies and gentlemen, we want to focus, we want to look at how the pandemic has affected the Black community. And last week we started this conversation. We want to continue, of course, but before we continue, before we move, proceed further, I would like Dr. Ayi tell us, maybe in 30 seconds, what else do we not know about Dr. Ayi aside your many accolades?
I am married. I have 3 sons who are in their teenage years. I love to cook. I enjoy sewing, and I love reading as well.
Brilliant. Okay, you enjoy sewing. My mom sews too, so she taught me when I was a little kid how to knit, mend my button when it go off, so I can at least mend my buttons. Dr. Mcgee, you want to tell us a little bit about maybe family? Do you like to? I know you are Shotokan, you do karate, but are you into? How about family? Are you into sports? Anything of the sort?
Yeah, I pretty busy guy. In addition to working as an ER doc and in our urgent care, I'm also the chairman of the COVID committee for 100 Black Men of Chicago. And so we're doing a series of talks just like this, doing one tomorrow, as a matter of fact. And we have maybe about 7 more of them, and it includes the youth.
Right.
Because the youth need to be aware of this epidemic and how it affects them. In addition to that, I'm also the national chair for the Firearm Violence and Injury Prevention Committee for the American College of Emergency Physicians. It's called FACEP. FACEP are all the ER docs all over the country. And so we have a diversity and inclusion section. And so I'm the chair for that. So we're actually trying to go out and find ways to prevent violence as well. Because as you guys know, as the number of people dying from COVID goes up, the number of people dying from gunfire has been going up. And it hasn't stopped. It's actually much worse. So we'll get into that a little bit later. And I like doing all the natural things that everybody else said. So we'll let you go on to the next person.
Brilliant. John just joined us. John, I hope you can hear me now.
Yes, I can. Can you hear me?
Yes, brilliant. Good. We can hear you now. John is a fine gentleman who has been like a brother. We have been chopping it up here in Chicago until he moved to Texas. He has a public health. He has a degree has a master's in public health. He's also currently working on his PhD. He is a disease intervention specialist and an epidemiologist with Prism Health in Texas. John, I know you have a beautiful family. You want our audience to know in 30 seconds how lovely your family is, or maybe something else that we don't know about you.
Well, the very first important thing is my family. Of course, I have 3 very amazing and busy kids, all under 7 years old. So, I'm
okay.
Yeah.
All right. No, thank you so much.
For now.
Brilliant. Thank you so much for that wonderful introduction. The reason why we do this is we don't want people to, you don't want our audience to look at our guests and think, oh, okay, they're just into, their work. We are humans, right? We feel what is going on in society. We observe what's going on in our society. In addition to your profession, you integrate in the communities and try to do your best to make it better than you saw it. So it's very important that we let our audience know that the guests that come on here are very much integrated in our community and are regular folks, just like everybody else who experience and feel everything that we all feel. But I'll start from you, Serwa. So, your observation so far with regards to this virus and how it has affected the Black community in your line of work. In the short, if you can synopsis, give us a synopsis of what your take is, and then we can go into the meat of the conversation this evening.
Okay. Where I serve, I live in the Midwest, so I haven't seen. Honestly, I have a handful of African American patients, and so most of the impact, honestly, has been from listening to the news about areas where a lot of African Americans live. but I used to work in a part of Maryland, which was maybe 90% Black. And I can spin off of that experience to not to fully explain this, but to think that, and at that time I was mostly managing HIV patients, and it really
Americans live
to find that a lot of them were not even going for their HIV medications, which was free. I was shocked to find that in 2018, at that time, I was seeing patients who looked like the HIV patients I saw back in Ghana in 1985, 1999, at the peak of the HIV epidemic. And so I noticed that there were some social determinants of health that affect people of color. A lot of it sometimes even cultural. Like, I still don't understand why the medications were free and people were not accessing it. Some were afraid. There was a lot of stigma with even approaching an HIV clinic, while their Caucasian counterparts were almost always fully on their medications and getting the type of response that we would expect at that time from HIV. So I realized there's a lot more diabetes, a lot more kidney disease, all because of the fact that there's a generational inability to access education, to access the healthcare system. And so people would have diabetes. You could tell they were progressing into kidney failure. And I just couldn't understand why they're not going to their endocrinologist and getting on what would prevent them from getting kidney disease. So fast forward, now I'm not working in an area which has a lot of African Americans, but then I hear all this feedback about the fact that you take communities or even the country as a whole, where African Americans make up 13% of the demographics, but then there's a disproportionate 60% of the deaths in America from COVID-19 can be attributed to people of color. And in some communities, it's as high as 83%. So, when I saw it, I was not completely surprised because I had a first-hand experience of just how difficult it was to convince people just to simply just access the healthcare system. It was free, it was available, it wasn't difficult, but for some reason, people were just not accessing the system. So I can see how that demographic is a reality, unfortunately, as it is today.
Great. So I'll come to John in a second. But Dr. Mcgee, this is the premier. Your urgent care is the first one in Hyde Park. Now, a lot of people probably don't. The ton of people who know about it. But for those who haven't heard about it, give us a little background and tell us your personal experience, having been being a doctor and taking care of patients, what your experience has been so far with regards to the pandemic and the Black community.
So, our urgent care is like the mini ER. We take care of illnesses and diagnoses that are not considered emergent.
Okay.
So we've been there for about a year, and we've been taking care of the community. Well, obviously, when COVID hit, that stopped. So we were not prepared. As you all know, and a lot of people are now learning that 25% of people who have COVID don't know they have it because they're asymptomatic. And so we did not want to put our staff at risk. And so we shut down for about 2 weeks till we got PPE, which is, the right equipment to prevent us from getting infected. We also changed the whole layout and the whole process for even coming into our facility. In addition to that, we even had to change our electronic medical record to get more with the times, which now is telemedicine. We're in a digital era right now. Mm-hmm. So it's changing everything all across the world as we do business, from education to your current job to future jobs. And so it definitely made a hit on small businesses all across the country. We were tremendously affected, and we're still affected. Our volume went down. And so this epidemic in itself is putting a lot of small businesses at risk, in addition to the people who are suffering. People are suffering. They don't have their jobs. They're being laid off. Some people are losing homes. Some people don't have food to eat. So I'm not going to complain about what happened to us, but that's our reality. Now, let's switch hats. From an ER standpoint, as an ER doc, I work in Gary, Indiana, and Maryville. Gary, Indiana has a high abundance of minority residents. And so if you guys think back when this first started, you know, the internet was getting it all wrong, right? They was telling people all the wrong stuff. Hey, black people can't get this. We're fine. We're good. And what they got that data from was the fact that in China, right next to China is Africa. And they didn't hear about any people from Africa being infected. So people automatically went and ran with it. But what we're not hearing was that the data and the ethnic data in terms of your race was not even being given out. You can't adequately say that, you know what, we're not being affected when you're not even getting the true data. And even now, we're not getting the true data. There's a few big cities that's given the data on the racial disparity, but we're still not hearing it from all the cities. And that's why you have, you know, people, Congresswoman Robin Kelly, who's with the Congressional Black Caucus, who started raising a fuss about it. Her and Senator Dick Durbin said, we need this data. And so it's ongoing. It's an ongoing process.
Okay.
And I'll move on, but I can tell you more about what I've experienced as the ER doc. It's horrible.
We want to hear that. John, your perspective on this, on how it's affected Black people, mostly, I would say, specifically Africans here in abroad, Africans back home, if you may, please.
Yes, I just want to say thanks to Dr. Mcgee for that, for really triggering something that I did mention in the last show. As it stands, let's even talk about Louisiana. I know I'm going to go a little bit across the globe, but just in Louisiana, already we have more than 70% of the death cases in the minority communities. We talk even in Maryland, it is the same, and many other states. Like he said, these numbers are not even given appropriately, so we do not really know. There are so many more. But let us even talk about how this affects Africans. I wouldn't want to say African, I want to say the Black people, because we have Blacks, African Americans in different countries, and how the kind of treatment that they face. We all know, and research and everything is very evident that this whole coronavirus, COVID-19, started from China. But how it turned around that Africans, especially living in China, and in fact, Blacks living in China, carried this burden on their head. They are accused of bringing the coronavirus in China. They are evicted from their homes, evicted from hotels. Some of them beaten in the streets, pushed out in the streets. In the moment where we have a pandemic, in the moment where everything, even if it has to do with immigration, has to be kept behind us so that we deal with what is a human factor here, that is this coronavirus. Africans, our Blacks, are being pushed out in the street. We also have a story, and this is also true, of a gentleman in one of the hospitals in Italy, abandoned in the hallway, and he was crying for his life, and we could hear, these videos are still everywhere in the social media, an Italian nurse telling him, "You are going to die." This is not even isolated, even back in Africa, these things are happening. But again, when we look at all of these things, we can't help but bring in the factor of racism in every corner of the world, the way Black people are treated. Back in the United States, Africans are dying from the coronavirus, just like African Americans are dying, just because we are all Black. And I think that the moment has come where maybe I'll bring this a little bit later, but I'll just like to point out that what Dr. Mcgee is doing in Chicago and in Indiana, targeting the African American or the Black communities and helping, spending all this time, I really, really want to commend it. I really wish that I knew you when I was in Chicago. I probably would have moved in with you.
You know, what's ironic is you weren't on here, but I have a master's in epidemiology and biostats too. So we probably could have been studying, because Epey was hard to heck.
So, Dr. Ayi, this is your field of study, and you've been looking at this for a long time. Can you, for the benefit of those who may not have probably, we hear of the virus, but take us through the behavior of the virus, the nature of it. They say don't touch your face, it's airborne, all of that. Okay, so what's the significance of touching your face? How does this virus travel and get into your system? Tell us the behavior of this virus and how and why it's so deadly compared to the flu, and maybe other viruses out there.
Okay, so the basic things we've always heard, which are still true, is wash your hands, put on a face mask as much as possible if you're stepping out of your house, and don't touch your face. Mm-hmm. And so let me start with why this virus is so dangerous. The first thing is that it is one that the human race has not been exposed to ever before. And so it started out, so it's a coronavirus. There are over 4,000 viruses known to man or known to infect human beings as a whole. And in the realm of viruses and who they infect, there are animal viruses and there are human viruses. The reason why animal viruses stay where they are and human viruses stay where they are is I try to use a keyhole analogy so that people will understand. Like at this time, you're living in your home. I don't have the ability to come to your house because I don't have the key to your house. Or really, I should not have the right to get the key to your house. Similarly, you cannot come to my house because you don't have my house key and I have not invited you. However, if for some reason I manage to go to a locksmith and that locksmith is able to get me a key that opens your house, like a thief, I can come in, right? And I can come and take over. So that's what happens with these animal viruses. So to speak, somehow they develop the ligand or the protein that allows them to attach to human receptor cells and therefore open the door to our house and then cause infection. So coronaviruses have been known to infect human beings since the 1960s, where the first two were discovered as causes of the common cold. And then in 1980, another two were discovered. And so up until 2002, we only knew there were 4 human coronaviruses. And they're called coronaviruses because they have these little spikes on the surface that look like crowns. So fast forward, in 2003, China experienced a major respiratory illness that looks pretty much like this one, except the mortality was 30%, meaning at least for those who were tested positive, as many as 30% of them were dying, compared to this outbreak where the mortality rate is about 1%. So it was very alarming. That's when China also built another hospital, like a big one, within a week. They managed to contain it within a short period of time. It didn't travel like it did as much around the world as this has, because China acted very, very quickly. It turned out it was a coronavirus, and that virus was called the severe acute respiratory syndrome virus. It was called SARS at the time. Now it has been renamed because this virus looks exactly like it. They share about 96% genetic material. So now this virus is called SARS-CoV-2, while the first one in 2003 is called SARS-CoV-1. So here's what happened. In that SARS outbreak, a coronavirus from a mammal called the civet cat crossed over and developed the key, so to speak. I'm just going to use my pen as the key, my pencil. It developed the ability to enter human cells and literally open and enter. And because human beings had never been exposed, it caused this severe respiratory illness with a high mortality rate. They contained it, and as of today, that virus is gone from the human race completely. Then in 2012, in the Middle East, specifically Kuwait, Saudi Arabia, United Arab Emirates, they also found that another coronavirus, this time had crossed from camels, a well-known camel coronavirus, once again had developed what is the key to enter human cells, invade rapidly, and also cause deaths. And that mortality was even higher, 60%, meaning 6 out of every 10 people who got this infection would die. Fast forward, in December, in Wuhan City, the hospitals noticed they were getting all these patients with these acute respiratory illnesses. And the physicians noticed that, gee, this looks a lot like SARS, you know, a lot of people were dying. So they started sending WhatsApp messages to each other. Their WhatsApp is the WeChat. So they started sending messages. The Chinese authorities heard, and some of them were actually charged with a crime of spreading false rumors. It turned out they were right. By December 30th, they had accumulated enough cases, enough people were sick that the Chinese authorities could not ignore it anymore. And so on December 31st, while we were around the world rejoicing to enter the new year, the Chinese authorities informed the World Health Organization. Now, remember this. Apparently, due to the international healthcare regulations of 2005, a country does not have any obligation to inform the WHO they're having an outbreak. In fact, if they don't go out of their way to inform WHO, it can get as bad as anything. The WHO doesn't have the right to just come into a country and just say, hey, you have an outbreak, let's come in and find out. But the Chinese authorities did inform WHO on December 31st. And so on January 1st, WHO got wind of it, and they sent a message around to the rest of the world that, look, be on the alert. China is developing a SARS-like outbreak. So on January 7th, the Chinese authorities were able to isolate enough tissue from the patients, and they were able to run it against their genetic library of pathogens, and were able to quickly identify that, gee, this is a coronavirus. It's one that we've never seen. And on January 12th, they were able to isolate the genetic material or the internal material of this virus. So here's what we've learned so far. The coronaviruses are envelope viruses. And maybe this is the best way I'm going to use. This is just something I picked off of my desk. An envelope means that it has a shell outside of it. And typically what would happen is this. Envelope means that it shares the cell membrane of human cells. And so really this virus cannot live without human beings. It needs a human being to live. So let's just say that I'm going to use a Ziploc bag to illustrate. So let's just say that this is a human cell, okay? This virus has developed a key to enter the human cell. Once it gets in, it breaks through the cell membrane. So let's just say it's inside. Once it gets there, it's going to command the cell, I want 1,000 copies of myself. So I need you to stop doing everything else and take care of me. I'm the visitor, but I'm the boss here. I need 1,000 copies. Now, because of that, the mitochondria, which is the organelles inside the cell that produce what we call ATP, our energy molecule, every ATP is now directed towards making 1,000 copies of this cell, of this new alien virus. And that is why one of the first signs and symptoms is tiredness. People just feel run down, and we call it flu-like symptoms. When you get a flu, you just say, I feel tired, I feel out of sorts. First thing people notice is tiredness. Now, it's going to create 1,000 copies. I'm going to use batteries as the copy. So it's making all these copies inside the cell. And then once it's finished, it needs to come out. And when it's coming out, it's going to bud from the surface of the cell. So it's literally, oh, I tore it, but it's going to come out. So let's say this is the new virus, okay?
We can see it. You have to raise it up a little bit. There you go.
It's coming out covered in a human cell membrane. So now there's a new virus. It's come out, but it's coming with a membrane. So that's what we mean by an enveloped virus. So there are two types of viruses. Envelope, that means there are different ways of classifying them. But when it comes to envelope, there are enveloped and non-envelope viruses. So envelope viruses include the Ebola virus, the HIV virus, and the coronavirus. Now, the thing about them, and I'll come back to why we wash our hands, why we use alcohol. This membrane is what we call a phospholipid bilayer. It's what makes up our human cells anyway, except this virus takes it with them. And because of this envelope, it will dissolve when you apply more than 80% alcohol to it. And once the membrane dissolves, it has to die. It won't survive.
Got it.
That's why we're preaching hand sanitizers.
Right.
On the other hand, if you use soap and water, which is actually way better than hand sanitizers, I know people run out of hand sanitizers and they get worried. But if you have running soap and water, you don't need a hand sanitizer. I actually haven't used a hand sanitizer. I only use it in the hospital because when you're in the hallways, it's easier to just squirt it on your hands. But the best thing is soap and water. It breaks down the lipid membrane, leaving the virus susceptible or vulnerable to die.
Right.
Okay, so that's why we're recommending wash your hands, use hand sanitizer, and then your eyes. If somebody, so the way this virus gets into our system, I'm still going to use this to illustrate, is to target the lungs. Now, every virus has its what we call tropism. The cells it likes to go and infect. So you take the hepatitis A, B, and C viruses, for example, whether they're coming through the blood or sexually transmitted, they want to go for the liver, and that is what's called hepatitis. They want to destroy the liver. This coronavirus loves the lung. That's its first port of entry. In fact, the receptors I was talking about, it has specific key to enter the lung cells. Specifically, it's going for what we call the alveolar type 2 cells, and it's going for one specific receptor, the angiotensin converting enzyme 2 receptor. It attaches to it, and once it enters the cell, it also activates another cycle that we call the ADAM17 protein, and that's what releases what we call the cytokine storm. It sets up an inflammatory reaction. So the first 7 days of the infection, when people get the actual infection, actually the first 14 days, this virus is just doing all that multiplication. So it's called the incubation period. You don't even know that you have the virus. During this time, you can spread the virus very, very actively. And then on the first day of symptoms, let's call that day 0, the virus continues to multiply. From day 0 to about day 7, people will have high-grade fevers because your body is reacting. Who is this stranger who is taking over the ATP and everything? So you have fever, some people have nausea, and then because it's going through the airways, people have a dry cough. And I want to emphasize the dry cough characteristically because it's not a purulent, people who develop tuberculosis, they produce a lot of thick blood-stained sputum. You won't see that very often. A few people would say, I have a little phlegm here and there, but it's a dry cough. Some people also say they feel like somebody's strangling them. They feel a sense of their airway being obstructed. But this goes on for about 7 days. And then characteristically, between day 8 and 10, the virus has multiplied enough. It's stimulated enough of these ADAM17 cycles, etc. And people experience a cytokine storm. So if you talk to anybody who's taking care of COVID patients, sometimes they'll tell you, well, the patient was fine. They were on room air one morning, and then within 4 hours, they got so short of breath, I had to intubate them. That is when you have a large number of people going through this. You see the ERs in China, like Dr. Mcgee's urgent care, they may experience a large influx of patients. You saw it in Italy. We've seen it in New York. The New Yorkers said it was fast and furious because suddenly you have all these people who have been incubating the disease for 14 days. They stayed at home for 7 days, and on day 8, they hit the ERs all of a sudden. They're all sick. And that is why in China, they did a lot of studies, and they noticed that most people come into the hospital on day 8 after symptom onset because they didn't see a reason why they need to go to the hospital for the fever. And in China, if you watch the news, there were people lining up outside the ER just waiting to get in, and they couldn't. But then when you are short of breath, the hospitals have to take you in. So this period of day 8 to 10, shortness of breath, can't breathe, high-grade fever, is characterized by high interleukin-6 levels. Don't worry about the medical terminology. Essentially, they get ill enough, and if they don't get medical attention, they go into what we call multi-organ failure, kidney failure, septic shock. Septic shock meaning blood pressure is falling, you're giving pressors, and ultimately, the people die from multi-organ failure. So even though there's no treatment, somebody is able to access the healthcare system. Some of them can be helped because 1, they can receive mechanical ventilation to support their oxygenation. 2, they would be given fluids and what we call pressors to maintain the blood pressure so that they don't die. But I think this is what caught the world's attention. 5 out of 100 people, or 5% of people who got to this severe state to be able to get into the hospital, got sick enough to require a ventilator, and some of them died. And for hospitalized patients, at least in China, the mortality was 11%. It means 11% of those who got into the hospital this ill died. That's about the age of 80. That was 15%. That was really, really high. And to put it in perspective, the common flu, 1,000 people get the flu, are sick enough to be hospitalized. Only 1 out of those 1,000 will get ill and enough to die. So the mortality of influenza is only 0.1%, 1 out of 1,000. So for this illness, even in areas where they're testing, for it to be 1%, that's 10 times the mortality rate of flu. And if you take hospitalized patients, that's 11%, right? That's 110 times the mortality of flu. And for 80-year-olds, that's over 150 times the mortality of influenza. So that's what makes this illness a really bad virus, so to speak. And in addition, besides the fever and the cough, which was the criteria for testing, now we've noticed over the last few weeks, we have all these elderly people, they'll tell you, grandpa is confused, he's not talking right, or maybe he fell down a couple of times, and we're quickly testing for COVID-19 because they come back positive. We found that it invades the brain tissue as well. And when we look back to the SARS data, you know, the SARS from 2003, we found that SARS affected the brain. In fact, there was one medical doctor, a young doctor about 32 in China, who developed the SARS outbreak, the SARS infection. He looked like he was getting better. Then he started having all these weird neurological symptoms. He died. And they did an autopsy of his brain. They found that the virus was well alive in the brain tissue. So now we know it affects the brain. And CDC and all these agencies are adding these symptoms to the presentation. And this is where it matters. In a place where you cannot get a test until you have certain symptoms, we need to add this to the criteria. Otherwise, we will turn infected people away, you know? So once they add these, then somebody comes in, we're not just focusing on fever and cough. We know to look out for falling down. We know to look out for confusion. We know to look out for things like nausea, vomiting, which, by the way, in children seem to present with abdominal pain, nausea, and vomiting, and the same for elderly people too. So okay. I haven't been long-winded, but I just wanted to give you a little, you wanted to know what is this beast we're dealing with. So you have it.
No, thank you.
Hey, I'm going home, bruh. She's already done it. That was magnificent. You don't need us anymore. Get all the high points.
Wow. Yeah. I mean, look. Yeah, you're right. I mean, after this, we just have to call it a day. But since we have time, let's just say we have time. So we want to play a little bit. All right. Let's have some fun. Well, so Dr. Mcgee, before I come to my brother John, she has eloquently given us the background, but your own experience dealing with, patients coming in and out. What is one thing that you have observed that gives you sleepless night when you go home and you would want the community to be aware of?
Man, it's crazy that you said sleepless nights, because myself and a whole bunch of docs are getting sleepless nights. And it's actually a phenomenon, actually. I don't know if you've heard of it, but it's called coronal nightmares. It's kind of like, and other people have had it. It's like where you're sleeping, all of a sudden you're sweaty, and then you actually feel you're surrounded by a coronal, and then you feel like you're suffocating. And then you kind of wake up.
Wow.
And there's people putting masks on and all this PPE. And so now when they're working, they feel like they can't breathe. And so then you get people dying in front of you. And so you kind of take that home into your subconscious. So you don't even really think about it because you're fine when you're talking to your friends or whatever. And then you get a call from a family member or a friend who said, look, my grandmother's in the hospital with corona and they're intubated. And then you get another call 2 days later. Yeah, my uncle just died. And then you get a call another 2 days later with the same stories going on and on and on and on. And so that's what we're hearing. And me as an ER doc and people that know me calling me, asking me what can they do. And not only that, people calling me just because their family member went to the hospital and they can't even find out what's going on. That's why. CDC shut everything down. So if your grandmother or your wife went to the hospital, it's a long walk by themselves into my ER. So when they get in there, they just seeing a bunch of faces that are not faces. they saying mask. And so imagine you're there, you're worried, you're scared, you're short of breath, and you're thinking, man, what's going on with me? And now the people that's coming in got a mask on, and they come in together, and they in there quick, then they get the hell out. They don't want to get it from you. And then you can't really call your family, because your phone may not even work. And then as you get sicker, you're on your own. And that's where we are with this. And that's why it's so frightening for everybody that people are dying all across the country by themselves. And then when they die, only 10 people can come to the funeral.
That's right.
And so people are have all this internal pent up frustration and post-traumatic stress disorder. Because your grandmother who raised you since your mom was working died suddenly. And so this is where we are. I train at NYU. I have colleagues who are at Amherst, who are in Queens, who are at NYU, where I trained at, who I know are going through it. You got a lot of things going on that is affecting everybody adversely, and it's going to take years to come out from out under this. And it's going to get worse. And then here's another piece. The frightening part about it is you don't know who got it. You don't know if somebody you've been dating, got exposed to somebody at their job, right. And now you guys hanging out and they're keeping you company and whatever. They may have it, and then now you got it. And who lives with you? Does your grandmother live with you? Does your 6-year-old son lives with you who has asthma? And now you just got it and gave it to your son? And that's the scary part about it. So from an ER perspective, we were having people coming in looking great, and you put an oxygen saturation on their finger, which measured their oxygen saturation, which should be above 96% to 100, and they're like 85%. And you're like, what the heck is going on? So it's just like Dr. Ayai said, it's attacking the lungs over several days, and you don't even know it. It hits you, and you have that cytokine response, and it's almost like a hypersensitive reaction, like somebody who had an asthma attack, or somebody who had a rash, and now they're having a major reaction to a bee sting, where your lungs closing up and you can't breathe. It hits that suddenly. And that's why a lot of times we're intubating. And by the novelty of it, by it being new, and as you guys know, the data has changed from week to week to week. And so we now know that when we intubate these people too quickly, we're probably killing them. And everybody's knowing that. So now what we're doing, if you had 85% and you talking to me, I'm leaving you there. I'm not about to intubate you. I'm going to put a little two-prong nasal cannula into your nose and try to get your oxygen saturation up. If that works, then great. Then if that gets worse, then now I'm going to turn you over into a prone position. And the reason why that's working, because when you're on your back, and you're intubated, only about 65% of your whole lung capacity is being aerated or oxygenated. So they're finding that just simply turning the patients over in a prone position can actually allow the posterior aspect of their lungs to now get aerated and oxygenated. And now people can survive that storm. And some people are going home. And this is all us learning over time. We're giving people antibiotics up front because you get secondary bacterial infections. Then you also get people who are getting clots in their legs called DVTs that can go to their lungs and cause PE. So we put people on anticoagulation, which are blood thinners, to prevent that from happening. And so we're learning over time, but I fear that we still don't know it all, because now guess what? We got 30 and 40-year-old people coming in with strokes who has no risk factors at all. We got kids in New York, who are now having these inflammatory reactions where they have this fever of unknown duration that no one can explain, but yet they're positive. But they're not dying, because most kids, and that's a loose statement, when they looked at the symptoms in the comparison for youth to adults, youth get all the things that adults get, except it doesn't really attack the lungs. And the thinking is that most youth have had exposure to coronavirus, because after all, it's the simple cold. So there's a small degree of herd immunity in our youth where they're not getting sick. That's why that rate that you see is way lower in terms of morbidity and mortality for kids. However, there are kids with asthma, there are kids with diabetes, there are kids with hypertension and heart disease who are susceptible. That's why our kids got to recognize you are not invulnerable. You can easily get your brother who has all these chronic problems, you know, and they can not do well and die. You can even have somebody who don't even know they got leukemia and now die because they're immune. Then also let's throw in the piece of HIV patients who are suppressed already. They had high risk. All my young black people running around here playing basketball on the courts, you know, got sweat dripping and fanning that sweat and partying in these little, house parties. They don't recognize that they're doing an injustice to our race because this is a bigger thing and it ain't going away. So that's why we also got to talk to us as adults. But we got to talk to our youth because they're carriers and don't even know it. And they think they're invulnerable and they don't realize they just killed grandma or they just killed their mother who has breast cancer. And so that's what the message we got to hit as well.
Thank you. Well, that is a lot of information you guys are giving us, and I really, really thank you for going in with your real-time life experiences. Before we come to John, we want to recognize folks who have joined us on Facebook. Joseph Akofa, my sweet, sweet, sweet little sister. She's here with us. Gregory L. Premio says, life-saving info for our folks. Thank you for your contribution, Gregory. Mobola Adewuni is also here. Hey, what's up, Mobola? Rebecca Mode is also here with us. She says, we are covered with the blood of Jesus. That's what Rebecca is saying. Osam Abuaji is also watching us. Yashua Hakim Aton joined us. Salasi Elliot Amekuji, my brother. What's up, bro? And Rebecca again says, thank you so much, Dr. Bertha Ayi, for sharing the information. And then Loretta Anthony is one of our favorite fans. Michael Otu is also a brother. What's up, Michael? Long time no speak. David Ziga says, thank you. Thanks, Alinko. Thank you, David, for joining us. Davidson is a realtor, a very competent one at that. If you want to buy a home in anywhere in this world, contact Davidson Ziga. David, I hope I'm right, anywhere in the world. But anyway, Alpha Diallo is also here. Faith Shimutai Chekwoni is also here with us. Sorry if I could not pronounce your name correctly. Castro Frimpong Manso Tikenya Miller is watching. Odo Akusia Adepa. How are you, Akusia? Victoria Timpo is also here. Sarah Bruce Duncan. And then we have Fatima, my own sister. Mausi Empress is also watching. Please share the feed. This is powerful information we are receiving, and our community definitely needs it. John, so you've given us, you mentioned how some Africans are suffering, are at the back end of the I'll say the effects of coronavirus, not just medically, but we are struggling as a black community. Now, do you have any, in terms of numbers, statistics, with regards to some African countries who may have contracted? Some cases in African countries. If you have that, please help us. If not, just tell us your personal experience dealing with patients at your hospital when it comes to the black community.
I would have really liked to give some data on a lot of the African countries that I'm so much aware of. But of course, it is just so difficult to get anything near accurate in terms of data in those countries. But let me speak a little bit for Cameroon, a country of my birth. It could be very shocking to hear from me that last week Cameroon have lifted the stay-at-home practice, and so everybody is back on the streets. When there is no intervention even in the country, we have less than 20,000 test kits in the country for about 20 million of people. So it is very, very pathetic. But again, South Africa, the cases keep also going up as much as many other African countries. So all these numbers, known and unknown, are very, very disturbing. I can't stop thinking about the people in Africa who have very, very limited resources, but also who are getting almost no education. Thank God that at least we have social media. We can text families on WhatsApp. They can watch YouTube. Other than that, they are on their own. It is also not only Africa. Let us come back to America in our African American community. I worked in the south side of Chicago back in 2017. I'm sorry. I was working in the community with referring people, helping people without insurance, at least to get some access to health testing, screening, general screening, like cancer, diabetes, and all of those very, very infections that can easily, be controlled. But so I ran into a lot of problems, access even to transportation. But let's even talk about the lifestyle. People are just so deprived that unemployment is a bigger issue. So if you are not employed, you do not have good income. If you do not have income, you are limited to what you eat. And all that we find mostly in those communities are junk food restaurants. And now we know what that means. That would tell us why we have a lot of cases of diabetes, the stress, people go through, from lack of just resources that could make their lives better. People end up with hypertension. There are just so many cases. Like Dr. Mcgee did mention, gun violence. People think they can do something that they can do to support themselves, and they get into these very poor choices. Let's talk about Fort Worth. I had an opportunity one time to go do a program in Fort Worth, somewhere around the south suburb of Chicago. There used to be Ford company in there. They deindustrialized that area, rendering all that community and the young people who worked in that company jobless. And what happened? If you go to that area, you have to mind the way you dress. You dare not even have your phone and expose it. They can be seized from you. You can get killed. So this is all, like I said in the very beginning, one cannot stop thinking that all of these things are just tied to all this thing of racism. This is not the first time that there's been an outbreak of a serious infection in the United States. And African American community or Black communities have always been, they've always suffered a lot. My question is, why is it that they have not found some kind of solution to improving the lives of African Americans or the Blacks?
Okay, so that's a good question. We would want, Dr. Mcgee, do you think that due to the unequal economic balance when it comes to the African American community or the Black community, you think that issues of poverty and deprivation of, what we call good healthcare and all these crucial things that the Black community suffers from contributes to the rate at which Blacks are getting affected by coronavirus?
So the answer to your question is yes. The rate at which Blacks are getting corona is not any fault of their own. It is the comorbidity that they have. Yeah. So that leads to a predisposition for corona to have a more profound effect upon anybody with that. And there are white people with diabetes who may die. There's just so many Black people and Hispanics that have diabetes, that have hypertension, that leads to a greater abundance of them dying. And you look at all the social determinants of that, and it's all about the have and the have-nots, right? So I grew up in every project in my little hometown of Gary. My mom, was a single mom going to school, and so we didn't have health care. And so now you look at other Black people like that. It's not any fault of their own that they grew up in those circumstances. And so now when you don't have that, you're working, little trivial jobs, And then now you have a school system where your education system may not be that high. And so if you're not a good student and your mom or dad has not been on you about, education, then you're going to keep that cycle going. If you haven't, if you're not, using birth control and doing all the right things, it perpetuates itself where you have more babies having babies. And so it's some things that we can do and take responsibility of. But I would never put any blame upon anybody of a different race. But those are some things that can contribute. So now when you go to college, and if you was at a school that didn't have a good education system, you may not graduate. And so now you stand in that cycle where you can't get in the upper echelon of getting good health care, of getting a good job. And so it perpetuates itself. And then now if you're in an environment where there's gangs and you're being bullied, you're going to join a gang because you're tired of getting your butt kicked. And then if there's access to guns, you may grab a gun one day because you've been bullied. Or, so all these little different things perpetuates itself. And that's a whole nother talk show. But yeah, it's healthy eating. If you're in an area where it's a food desert and you're not getting nutritionist food, or if you don't even know to eat nutritionist food, you've been eating McDonald's and chips and stuff, you're gonna not be healthy. So and then also we got some family stuff like there's a relationship with diabetes that runs in your family. Hypertension runs in your family. You have no control over that. That's the hand you've been dealt. And so but at the same time, are we getting the resources we need to do better? Does the president and Congress care enough about us to give us the funds we need to get out of this cycle? Are they putting the resources where they need to be? Should there be grocery stores instead of liquor stores? So there's a lot of things that we could have to get help to get us out of this. And not only that, are our professionals going back and mentoring a young man, a young boy, a young girl to say, hey, you can do better. You can be what you want to be. Look at me. And so I encourage everybody on this call, if you're successful, go back and grab a kid, show them the light, show them what they can be doing. Because that's what drives them. Instead of letting them see, somebody who's selling drugs and driving a nice car, let them see you as a epidemiologist driving a nice car and say, hey, I went and got my master's in public health. It was hard, but I did it. So you can too.
That is very brilliant what you said, because prior to COVID-19, I know a lot of people have been engaging in the conversations of, the food healthy eating, maybe exercising, and exactly. And usually these are not popular conversations in our communities. Now, do you think that COVID now is bringing us to a point where the Black community should now take these essential things, these things that we probably were not paying attention to in terms of exercising, eating well, making sure that we're spending our money, not only on the nice things like buying shoes and gadgets and all that, but investing money in the food, the kind of food we eat. Our healthy lifestyles, it goes a long way. Not only when COVID hits, but it's just it has to be a norm. It has to be our new way of life now. I think, if not for anything, COVID is telling the Black community that now than ever, we have to start paying attention to our health habits like never before. And in this case, how do we begin to change the conversation from civil rights, poverty, and make sure that our conversation is inclusive with regards to healthy behaviors or healthy habits? And I think this is something that we will have to be talking about more and more now from now onwards. What do you think, Dr. Micheal?
So look, man, I don't think COVID's making anybody do anything. It's us learning to know that we need to do these things. If you're a creature of habit, you're gonna still eat the wrong stuff, even though you're in the house. When you looked at the grocery stores, chips and stuff were gone. The produce section, people are not really hitting. Right. So we got to do more in terms of us educating people. But then some of us don't have laptops or access to this digital era we in. So it's a complicated process. You know, but I think we have all these organizations doing this, what you're doing, and everybody kind of like joining hands across America and supporting African Americans and giving all this key knowledge. Then eventually it'll trickle down and we'll get it. But then we also got to hit the kids. And the kids are not necessarily on Facebook Live, as I'm learning. They're on Instagram. So you got to find an innovative way to get to them and incentivize them to do these things and to listen so they can learn, and then they can modify their eating habits, their exercising habits, their social habits, and preventive habits.
Okay,
that's what we need to do.
Dr. Epey, before I come to you, just want to mention a few numbers with regards to the African countries and some and their confirmed cases. There are 55 countries in Africa. I'm not going to bore you all with all the numbers, but I'm just going to say a few important ones. So in total, I think the numbers we have about on the continent of Africa, we have about 50,996. So close to 51,000. That is on the entire continent of Africa. And again, Africa has 55 large countries. The ones that are significant, Algeria is not necessarily a tropic area. Correct me if I'm wrong. They have about 5,000, almost 5,000 cases. Burundi has 2,265 cases. Another country that has a lot of cases is Egypt, 7,588. Some people would attribute that to a lot of tourists going in and out from that country. And then you have Ghana, which is 2,719. You have Guinea-Bissau, 1,856. Another large number is Mauritius. Mauritius has 5,400. 5,400, and Nigeria has 2,950. Now, Nigeria, as we know it, has a very large population Lagos and Nigeria has a very large population compared to some of these countries, compared to Ghana, compared to Mauritius, which has a higher number. So you would wonder why a country of size of Nigeria with a large population of people in terms of density having lesser than Mauritius, which has a lesser population. So maybe Dr. Epey can help us with that after I've going through this. And then South Africa also a very cold country. Is not too cold, but of course it's a cold country. It has 7,800. The country with the least, okay, I think I have to say this, is Seychelles with just 11 numbers. Seychelles has just 11 numbers. And then Mauritania. The reason why Mauritania is very interesting is Mauritania only has 8. Lesotho has 0, nothing at all. And so there's news that Mauritania has found this natural concoction or this herbal medicinal concoction that actually, it's like tea, that actually cures coronavirus. And we'll come to the cure because I know Hemesvidere, is it Hemesvidere? What's the name? Can you help me with the name of the new
UV light?
No, the new cure for coronavirus that UV light.
And the way to remember it, I tell people my own acronym. Think about the word remedy for severe disease. So just take remedy, severe. Remedy for severe disease.
Thank you. Yes. Okay. So
also UV light though.
Yeah. Oh, UV light. Okay. We'll let you tell us. We'll come to how we can suppress or cure it and all that. But Dr. Epey, these numbers, I don't know if you've seen them.
Yeah, I'm quite familiar with them. So thank you very much. Sana, first of all, I want to thank you for what you do.
True.
For putting a platform that allows such discussion and even the idea to talk about it. I think that's great.
Thank you.
For Dr. John Oben, I have not read your CV. Anytime I get on a panel, I like to know who is who. I didn't get yours, but whatever you've done to get to where you are, I congratulate you. It's not easy to finish high school, much more go to college and become a physician. So thank you for doing what you've done so that you could be a blessing to the world. And for Dr. Michael Mcgee, you have done so much. I couldn't get enough of your CV. I mean, you've gone to school and
Look, I'm looking at your CV like, what? No way I could do what you're doing.
Yeah, so
I get it.
really appreciate that. I mean, you're faced with as many obstacles as possible, but for you to persevere in spite of all the distractions to get to where you are, I really appreciate you guys, and I'm glad to be on a panel discussing with you. So first of all, Africa. So the good news, I know Dr. Epey was mentioning that we don't have this, but I have really, really good news. That a lot of people don't know this, but after the Ebola outbreak in 2015, Africans came together to form the African CDC. And a lot of people don't know that. And I have physicians asking me, what is Africa CDC? Where are they? Well, Africa CDC is a special technical division of the African Union. The concept was formed in 2016, and they were inaugurated in January of 2017. And the director of the CDC is a very, very renowned physician by the name of Dr. John Kenkasong. And he has run he worked for many, many years as in the US CDC, and I've even been told by reliable sources that he was tapped to come back to the US even with this COVID-19 outbreak, but we also happen to need him. So the Africa CDC is alive and well, and the good news is they're coordinating an African strategy, which is really, really helping. So I don't want everybody to think, oh, Africa is poor, we don't have anything, and we don't know what we're doing, and people are dying. No. In fact, if you go to the Africa CDC website, you would find the numbers that, we said we couldn't find. If you Google it and send out, I have sent you a bunch of screenshots that I took from recent conferences. Go to Africa CDC, you would find the latest numbers. Today is May 6th, so their numbers are about a day old, but it gives you the numbers, it gives you the country breakdown. Okay. And I just want to, in a nutshell, tell you what Africa CDC is doing. So on January 22nd, when Wuhan, the WHO technical group was meeting to decide whether this was a pandemic or not, they met on January 22nd. They decided that, look, this thing is not severe enough to call it a public health emergency of national significance. They met again January 31st. They declared it a public health emergency of international concern. Just 3 weeks later, on February 22nd, all the ministers of health of the 55 African countries also met in Addis Ababa. So I've sent you the pictures to show you they met. They also taking COVID-19 seriously. And on that day, they set up what they call an African task force for management of COVID-19. It's called AFTCOR for short, African Task Force for the Management of COVID-19. And they set out on a 5-pronged strategy. First of all, they empowered a task force that would be dealing aggressively with this. Not only aggressively, we had learned from Ebola that the thing that stopped Ebola was not even foreign aid. A group of private African people got together to form what is called Afro Champions. And they were able to raise $40 million, and they sent healthcare workers to all these Ebola-stricken countries to help curb Ebola. Afro Champions is an organization that is alive and active, and also alive enough to be helping the African CDC. So the African Task Force has 5 branches. One, Clinical Management and Severe Infections Branch, which is overseen by Dr. Natalie Mayat of South Africa. And I happen to be tabbed as one of the members of the Clinical Management Task Force working directly under Dr. Natalie Mayat. The second group is the Risk Communications and Community Engagement Strategy, being overseen by Dr. Mousif Mohammed of Morocco. They have their achievements, and I'll share those. The next group is the Surveillance and Points of Entry, being overseen by Dr. Linda Makayoto of Kenya. There's the Laboratory Diagnostic and Subtyping Group, which is being overseen by Dr. Amadou Alpha Sali in Senegal. Now, if you realize, Senegal has always had a connection with France, and they have one of the best labs in the world. In fact, one of the world's 15 labs run by the WHO is in Senegal. The them on the continent of Africa, Johannesburg and Senegal.
Mm.
WHO has 15 labs that you can count on if you're not sure. Senegal has one of them, and the head of the Senegal lab is the one overseeing the laboratory diagnostic and subtyping for the African Task Force. And finally, you have the infection prevention and control being overseen by Dr. Chikwe Ehekwezu from Nigeria. He is the head of the Nigeria CDC. So, and all these people are actively tapping the best of the best of the best of Africa diaspora who can help it manage COVID-19. And so every week on Tuesday mornings, this task force of about 60 people will meet to get an update. So I don't want anybody to think that, oh, Africa is out there and we don't know what we're doing. First of all, we have very good leadership. And secondly, we have 5 branch task force authorized by the ministers of health who are actively working. And I want to tell just briefly, I shared the screen with you, but this task force has technical working groups, surveillance, clinical management, supply chain. They're looking to tap African mask producers, ventilators. We're looking at a lot of things. Senegal and Ghana already have their rapid test, homegrown rapid tests already done. Then they have regional health coordinating committees, East Africa, Central Africa, West Africa, Southern and Northern Africa. And if you've been watching the news, sometimes these are economic branches, not so much health. So sometimes like maybe the president of Ghana or the president of Rwanda would meet one of these regional groups and give an update. The goal of this work task force is threefold: prevent disease, prevent death, and also mitigate the social harm from people staying at home, etc. And they've made quite a lot of achievements. In fact, in the next 4 weeks, they're planning to roll out 10 million COVID-19 tests across Africa. In the next 2 weeks, we'll roll out 1 million. And these working groups have done a lot of work. So even the surveillance, they've trained over 18 plus countries. 80 participants have been trained. So far as infection prevention is concerned, more than 45 participants from 22 countries have been trained in infection prevention. And if you listen to Dr. Kenkasong speak, he would say that in January, if you say COVID-19 was hitting Africa, it will be mayhem. But today, all these measures have been put in place. More than 45 countries have the ability to test for COVID-19 in-house. People have been trained on risk communication. The thing we have to do is what I'm doing now. We need to market the Africa CDC to let people of color and Africans have some level of confidence that things are being done. In fact, I'm also vice chair of a task force that came out of this African task force. It's a private-public partnership. We're looking to raise $400 million to help this Africa CDC to achieve all these things it's doing. Now, you realize that Africa has 0.05% of the world cases of COVID-19. Currently, we're hitting 3 million. Africa has only 50,000 is a lot, but we have a small number. People have attributed many things, including, Africans are immune. Now we know that's not true.
Right.
That's the history of what's happening in the Americas tell us that Africans can get hit and get hit hard. So that is out of the window completely. Now, what is happening in Africa? If travel restrictions had been put in place, Africa would have 0 cases. And I know this because all these lab networks across Africa, they've been studying coronaviruses. And in fact, you may or may not know this. If you Google Kenya and coronavirus or Ghana and coronavirus, these are 2 countries where the scientists have been studying coronaviruses. And so they come up. That's not to say that coronaviruses are only in Africa, Kenya and Ghana. But if you look at these 2 countries, their scientists have been studying coronavirus for years. And so you would have literature popping up. And we do know that African bats have had coronavirus, but they haven't, like I told you, they don't have the key to cross over to infect humans. And so just studies, even in Ghana, studies done in common cold, we found that 3 to 4% of the common cold in Ghana was caused by coronavirus. The previous 4, not the novel. And so we do know that Africa did not have the novel coronavirus. And in fact, since the WHO sent the genetic material to Africa and all these countries by mid-February, we've gone back to December. just like New York and all these countries, all these states are going back to see, like Chicago, they're finding out that maybe they had COVID-19, maybe even before December. Africans have gone back to check their respiratory samples, and they're not finding the novel coronavirus. So we know Africa didn't have it. Africa had its first case on February 14th when a Chinese national visited Egypt, and that was the first case. Then the second case was in Nigeria on February 27th when an Italian traveler came into Nigeria, and 100 of this person's contacts were traced. One of them tested positive. And then the third Nigeria case was a girl, a lady, 31-year-old lady who had traveled from UK. So for the most part, Africa started importing cases, mostly from Italy and France, these two countries, and then the rest is history. So really, Africa as a continent would have been free of COVID-19 completely if it wasn't for the fact that there were no travel restrictions in place. Ghana, for example, my country, as of the 21st of March, they put in a travel ban. In fact, a week before that, they said no government official could travel because they noticed that, look, people were importing coronavirus into the country. So let me speak to Ghana, for example. Just the 2 days between when the president announced that we're having a travel ban and when the travel ban went into effect, 1,030 travelers came into the country. They were immediately placed into forced quarantine. How many of them tested positive for coronavirus? 105, 5%. What does that mean? Oh my God. For 3 months, Ghana was literally, and I'm sure for every African country, we were importing coronavirus. So that the 50,000 is a reflection of human-to-human transmission from cases that have come. So South Africa, for example, their cases were from Italy. They had travelers who came in from Italy. And then if you also notice, every country that went and evacuated people from China, I can name them: Italy, Spain, all these European countries, even the United States of America. America had 0 cases until it went and evacuated its residents from Wuhan City. 3 of those 800 people were the first positive cases in America. And then America went back to bring the people from Princess Diamond back into the country. When they were bringing them, only 14 of them were positive. And instead of quarantining them like the CDC recommended, the State Department said, well, we're not going to listen to medical advice. We're going to bring them. And not only are we bringing them, we're going to split the 14 people into 2 planes, put them on the back of 2 planes, and then split the 380 people to sit in the same plane with them. That was an infection control disaster. How do you put uninfected people in the same plane to travel for more than 10 hours? Well, by the time they got to the United States, guess what? The numbers had gone from 14 to 45. And so mid-February, the US had only 103 cases, mostly imported. And then human transmission started. So if you think about it, from 103, now the US is what, 1.3 million? And so Africa mostly had it. So the summary of what I'm saying is this: Africa's cases were imported. Human-to-human transmission has started. We should have put certain measures in place, but we have it, but we're doing something about it. So I don't want anybody to ever think Africa is helpless. No, we're not. And this time, instead of allowing maybe a rich country like South Africa to do everything, the Africa CDC has a continental strategy. Like I'm saying, we're raising funds. This week, we're collecting data from every country. Give us your number of ICU beds. Tell us how many intensive care doctors you have. We want to keep a tab. If your cases go out of hand and you need help, we're sending help. If we have to tap into diaspora physicians like myself to do telemedicine, we're doing it. Already Ghana is doing it. We have a WhatsApp group with all the intensive care units in Ghana. They will tell us if they need help. We do Zoom training. We do Zoom conferences. The Africa CDC has a webinar every Thursday morning. It's 1 p.m. in Kenya, but in the US, it's like 6 a.m. Eastern time. You can log on and listen to real evidence-based learning. And on Saturdays, they have office hours, meaning any physician, whether you live in the US or mostly it's for Africa, you can log on to this Zoom conference. It's broadcast on Facebook Live. If you have a question, you have a dialysis patient, you're not sure what to do, you can ask your question. In addition, there are over 21 clinical trials going on, mostly in Egypt, looking at remdesivir, plasma, all these things. So Africa is not behind. We're really keeping up to date and talk even about America.
Okay, we'll come to that.
No, I just want to finish with Lesotho. So they say Lesotho doesn't have numbers. If you don't test, you will not find. Let's assume America had 0 tests. All we'll say is that people are dying and that we have 0 cases. The minute we started testing, out of our 300 million, we've tested 5.6 million. It's like a quarter of America is infected. So Africa would test, and we would know our real numbers. But I just wanted to give a spin on what Africa CDC is doing and what is going on in Africa. I hope I didn't talk too much.
No, you didn't. You were actually giving. I mean, you were feeding off the information that you were giving us, and we really appreciate it. We'll come to you again. What I just wanted to appreciate folks who have just joined us. Demetrius Thomas is here. Gail Hall just joined us. Nee Okai is also here. Ronald Jackson, Armstrong, Imemi says, excuse me, African don't have good leadership. Yeah, that has been our problem. Another day for that conversation. Stay tuned, my brother. What's his name? Armstrong. Stay tuned. We'll be having that conversation very soon. And we also have Hassan Matavu just joined us. He says, hello, panel. Hassan has a comment here. Excuse me, I want to read that real quickly. He says, very resourceful information I am hearing. Very resourceful information I am hearing. Tanzania President Magufuli has claimed goats and sheep have tested positive, casting significant doubt on authenticity of test kits. How are Africans ensuring accuracy of test kits? I'm sure my brother John is still here. Okay, John is here. Now, before I come to Dr. Ayi, I would like you to come back to the cure, chloroquine versus remdesivir. Of course, chloroquine, I mean, there are rumors that it helps, it cures, but we'll let you expand on that. Dr. Mcgee, if John will come to you in a second. John, are you still with us?
Yes.
Okay, great. But Dr. Mcgee, I know you also have been doing a lot for the community with your the Chicago 100 Black Men. Chicago, am I getting it right? Chicago 100 Black Men?
100 Black Men of Chicago.
Great. I think we're getting feedback. I'm not sure if it's John, but if you have a cup or something by your side, please help us. I'm not sure where it's coming from, but okay. Well, Dr. Mcgee, how is your organization helping to enlighten the community to stay awake in this pandemic crisis? And how do we as a people mitigate some of the things? Because even staying at home is giving a lot of people that mental depression. You know, there's a lot of stress. And how do we handle that kind of stay home stress and as a people? And more so, what is your organization doing about it?
Can you hear me?
Yes, we can.
Can you hear me? Okay.
Yes, we can.
All right. So yeah, that's so actually two things. Number one, even though it's a dichotomy, right?
Right.
We know we got to get out and work, but then the numbers are going up. In Chicago, they just had the highest number of people to die in one day than they did the whole time we've been in this. They had 135 deaths. Over the past 10 days, they had over 100 deaths each day. Originally, it looked good because I've been following the curves. It was going down to like 64 in a 24-hour period, 75. But over the last 10 days, 100 people or more have died. And overnight, it's been 135. That's data that's out there. You just Google Chicago and Corona. And so you got people who want to work, but if they're gonna make it happen, which it seems like it's gonna happen, we just got to be smart. We still need to socially distance. We still need to wear our mask. And not only that, I'm seeing all kinds of people wearing a mask like this. You can't do that. You got to cover your nose. And when you do it, there's a little wire right here. You got to conform to your nose. Because if you have all that space in between, the saliva that someone just spit in your face can go right into your mouth. So you got to, people are wearing it upside down. The wire, the hard part should be in the top. Also, people have a false sense of security thinking that this mask, if they wearing it and the person they talking to doesn't have a mask on, they think they're protected. This mask only keeps your saliva and secretions inside. So who's ever spitting on you, who's not wearing a mask, can still infect you. Are you guys still there? Alinko? Where'd he go? I think he left. So this right here is an N95. This will protect you if someone else is spitting on you. But you may also want to have glasses on as well. I think we're having technical difficulties. Can you guys hear still?
I'm here.
You can hear? Okay.
Can you hear me?
I can't hear you though. So what we're doing. So 100 Black men are having all these different talks. And not only are we doing talks about COVID, we're doing talks like next week is going to be on prevention and wellness and nutrition. The week after that, we're going to look at uncovering the CARES Act.
Before you continue, can you help with the nose mask demonstration? Because that was when we were having a technical difficulty. So I think people may have missed it.
Do it again?
Yes, please, if you may. Okay. Due to the technical glitch we had.
All right. So this is a surgical mask. There's a wire, and people are wearing that mask like this. You got to cover your whole nose and make that wire conform to your nose.
Okay.
And it got to be tight up in here. It can't be wide open like this because saliva can still get into your face.
It makes breathing difficult though.
Yes. Also, if you're wearing this little thin thing and the person you're speaking to is not wearing it, this does not prevent you from getting it. It prevents you from giving it to them. So they're protected, not you.
Okay.
So if they're spitting on you while they're talking or sneezing or coughing, even though you have a mask on, you're protected. Now, if you had on this mask, where is it? Which is an N95, or even this mask, that's an N95, they can protect you. The other thing about these masks, and you guys are going to hear about this, I'm going to encourage all teenagers, adults, whatever, but I think everybody, especially at night, should stay away from these black masks. All right? Because we're already being racially profiled. You already got police scared thinking we're going to rob or do something silly. And you got other people with guns who bought up a lot of guns because guess what? Gun stores were considered essential. So it was lines of people buying guns. They think it's a revolution. So you got to stay away from these black masks and any of these dark masks. Also, for my youth, you guys got to stay away from red masks, which can be Bloods, or blue masks, which can be Crips. So it's so many different things you got to navigate through with these masks. So try to wear bright masks, try to wear the surgical masks, try to wear the N95s, most importantly, and try to be careful with the mask. And so what 100 Black men is doing, we have a series of lectures we're doing that talks about a bunch of different things. Next week's talk is going to be on prevention as well as nutrition and healthy eating and wellness. So we're trying to tell you what you can do to prevent you from getting corona. The week after that, we're unpacking the CARES Act so that people can know what's out there for them. The next two sessions are really for the kids, and then I'll be done. So basically, we're doing a talk on re-entry into society on May 28th, and it's called The Impact of Gun Violence on Our Youth. And so for that talk, we have the Associate Chief of Trauma from University of Chicago, Dr. Brian Williams.
Okay.
We have the Chief of Police, Chief Brown from Dallas. We have hopefully Lori Lightfoot. We're waiting on her to commit. And basically, we're going to highlight things that kids can do to prevent themselves from being shot or killed and prevent violence among the epidemic of COVID. And now we're doing, as a organization, we're doing a challenge to raise awareness. That challenge is called Mask On, Violence Out. Mask On, Violence Out. And so we're asking every junior high school and high school student who are minorities and African Americans to be in this contest. And so we're going to be announcing this tomorrow. And the contest simply is you basically create a TikTok video showing yourself making a mask, a bright colored mask using 5 colors that are not dark or red or blue. And now the top 5 TikTok videos that has the most likes and shares, we're going to win prizes. The second part of that is the violence out. So we want and again, the same students to create a video showcasing themselves doing a rap, dance, song, spoken word, whatever they want to do, sitting on violence prevention. And we're going to shop these around, and we're going to have the social media to vote on who's going to be the winners. And now once all that's done, we get to May 28th, we're going to announce the semifinalists. The following week, when we announce the finalists, which is the what are you going to do this summer talk, we're going to basically have those finalists get on Zoom, introduce themselves, tell us what they're doing that summer, and then all this is going to be on the radio station, Power 92.
Okay.
And the DJ is going to be talking about these kids and winning this contest. Once we get those final masks, we're going to try to get mass production of those masks, which are going to be bright colors to be produced, and we can now sell to the community, and a portion of that will go towards violence prevention and the things we're going to be doing. And then we'll come back again in the summer with a bigger challenge with bigger stakes. And by the way, first prize is $2,000 for each winner. Second prize is $1,000. So this is going to be something that's going to get the students to really want to be involved with it.
Okay.
And so we're going to be doing talk shows. We're going to be raising awareness about everything you guys talked about. Wearing your mask, healthy eating, dieting, eating the right foods, preventing violence, locking your guns up. Parents, you bought all these guns, lock them up so your kid can't get it and shoot themselves. That needs to be done. That's the message we're trying to spread. Thank you.
You're welcome. I want people to understand the background of 100 Black Men, Chicago. Is that just 100 people there? Just a little background so people can understand who you are,
So it's a concept, and the concept was born out of the need for Black men to be visible, for our youth, for our young ladies, but mainly for the young Black men who are seeing bad visuals of their dads in jail or not doing good things. And so we basically target youth and we mentor youth. And they have all these fundraisers, and it's a lot of people who you'd be amazed who are in 100 Black Men, and they're all across the country. They're national. Every major city, there's a 100 Black Men chapter. We just happen to be 100 Black Men of Chicago, and they're way more than 100. And we have police officers, we have firemen, we have athletes, we have any and everybody who are actually in this particular organization. And so nationally, we're trying to get this on a national scene where we want to wear masks, prevent, COVID, and then prevent violence in our youth. So we're trying to basically roll this out. And right now, Chicago and Gary, Indiana, where I'm from, is going to be the pilot study for this campaign awareness.
This is excellent. In a few minutes, we'll have you put a lot of information in terms of how people can reach you or how people can, get involved and whatnot. So, but John, we've had, we've talked about how coronavirus has impacted the Black community, both here in the diaspora and also on the continent of Africa. But what would you say that you see on a daily basis that you would want to leave the Black community with to pay more attention to, apart from everything else that has been discussed? I mean, we want to be practical, so in your day-to-day, what do you come across that you think that, this is something that we have not been paying attention to that you would want us to start looking at?
I can hear him.
Yeah, I think we can hear you. Okay, so we're having issues hearing my brother.
Is it better?
Yes, John. Okay, we couldn't hear anything you were saying. So can you please start if you may?
Okay, so saying that one thing that I like for people, especially we, the Black people, to know is that coronavirus is real, and yes, it does kill Black people from even the age of 1 to 100. So it is there, and we should be very, very careful. I did share a story last time when I went to a barber shop to have a haircut, and a gentleman asked me if coronavirus does kill Black people. And when I turned the question around to him, he said, hell no, it is a white man's and the Chinese disease. So that whole notion is what I'm not sure how many are watching, but we should know and be very, very aware that coronavirus, I'm sorry, the kids, it's not
okay.
only a white man's infection or a Chinese infection. I work with in an African American community. It's a mix of African American community and Hispanic community here in Dallas, downtown Dallas. We are in infection disease prevention and all of that. So what we do is kind of track the victims, and we see who is in care and who needs help. So we have a hotline and all of those. We do not try to go meet them where they are. We only do this over the phone and sometimes through Zoom. But it is still disturbing when people still do not believe that coronavirus is real. In Dallas, as of 4 days ago, we had only in the city of Dallas over 250 cases as of just 4 days ago. So this happens, we have over 100 cases a day only in the city of Dallas, not Texas. This is how serious this thing is. And just people should just change behaviors. We should, like Dr. Mcgee said, Dr.
Serwa, Dr. Pierre.
Yeah. All have recommended, and of course, these are all recommendations from our various health departments and even the CDC and the states and all of that. It's almost that we do not really pay attention. I wonder how many Black teens, and I'm saying Blacks because I am Black and because I'm talking more about Black, they are more likely not to watch the news because they listen to pop music and all of that. What Dr. Mcgee is doing is something that should be done all over. If we have people who can do that, meeting them where they are.
Exactly.
Programs like our program where it's targeting those youths, meeting them where they are. What do they do? Where do they do it? If we meet them there, they will realize that really, I didn't know about this. I didn't know it was serious. Well, I heard about it, but it didn't kill any of my family members, so I didn't really know how serious is it. So I think that meeting them where they are and all these educational programs with the motivation, like the prizes that you said, it's really, really going to motivate, it's going to educate, and behaviors are going to change.
Exactly.
The number of cases perhaps in the Black communities is going to reduce.
No, you're right. I think that you have I'm still getting that crackling feedback. I think it's from John. I don't know if you're moving your phone.
John.
Yeah, thank you. It stopped. Okay, great, good. So you were the bad guy. We got you. John, a lot of Africans, are you charging your phone perhaps?
What? Wait a minute.
Are you okay? Are you charging it?
Yes, it was on charge, but I took it out of charge. It's still doing same.
Okay, so it's just maybe from the manufacturer. Let's just put it on the phone. It's not you. So if you can help us, Africans, say that there are some teas and some herbal medicines that you can boil to strengthen your immune system. You know what? Can you lift it up? Can you lift the phone up? Maybe it might help the noise. Yeah.
Oh, is it better? Can you hear me? Can you hear me?
I hear you, John. But I think they're frozen.
I think so.
Wow. Dr. Aya?
I can hear you.
You can hear her? Okay.
Yes.
John Olinko?
Yeah, I can hear.
He looks angry. So, Dr. Aya, so you said they're going to have 200 million tests?
No, they're rolling out at least 10 million. Initially 1 million and then 10 million. But that's just from the continental perspective.
Okay. Ladies and gentlemen, I think we are back. Okay, so because of the feedback from John, we'll skip John and go to Dr. Bertha. Okay, let's go to Dr. Bertha because it's nice. I think it's some technical thing that's going on with his phone. But Dr. Bertha, so how about this immune boosting thing? And before you do that, maybe you and Dr. Mcgee can help us. They say something about virus flora, like you have to get exposed to, you have to go out and get exposed. That's how the immune system fights virus. You have to be exposed to fight it to get immune. Now, we're not going out. Go ahead. Okay, fine. So take it from there. Help us. I mean, we're not going out. We're not. So do you think that as a result, if this is true, I mean, tell us about that. Do we have to interact and get infected with virus and our body fights it and that's how we get immune? And if that's the case, okay. If not, so all right, then help us understand how this teas and this lemon and all the sobolo things we've been drinking, how it helps the immune system, if that is true.
Okay, Dr. Mcgee, you have to go first and then you can add a little bit too.
Yeah, I'll just be brief. I'll just tell you, so think about that. For a new bug that we don't know a lot about, is changing every week. It's killing. First, it was killing only older people. Now it's killing younger people with strokes. They're having heart attacks. You don't know enough about it. I wouldn't want to take the risk of herd immunity if you're the 1% or whatever percentage, 3 to 4% of people who get it have high mortality. You would not want to be that person. So I don't know if that's a good option because you may be the one to die from it. Now, herd immunity usually happens on its own. Once enough people get it, a small 20% of it don't get it, and then they're kind of not affected by it because 80% of the population has it. Right now, we don't even know how many people have it. We're not testing kids. Kids could be carrying this, and you not even know it. And so until we test everybody and do, the sourcing of where it's coming from, there's too many unknowns.
Well,
that's it.
Dr. Ai.
Yeah, so let me tackle it from a few aspects. In general, and I'm saying general, I don't want to be specific to one thing. First of all, let me talk about immunity and treatment. So in general, if you notice, a lot of viral infections, you can actually cure a virus. You can suppress it until it gets out of your system. Let me give you just even 3 common examples. So HIV infection. We quickly found that the antibodies don't mean anything. It is the antibodies or the body's immune response that's actually used to do the rapid HIV test. Somebody's going to say, I'm going to get a urine test or a swab in my mouth or blood test for HIV. You're actually testing the antibodies or what we thought was supposed to be the immune response to the virus, but it actually does nothing to the virus. So for HIV, for example, there's no cure. People would suppress the virus for as long as they're taking their combination of drugs. If they get off on it, or maybe they miss even just 30% of their pills, the virus will rear its head right back, and they can progress to AIDS like never before. Take hepatitis B. At this point, hepatitis B has no cure. It's very, very common in Africa. It's the #1 cause of liver cancer in Ghana and several parts of Africa. It has no cure. In fact, most Africans don't even take medication because it's so expensive. But you can suppress it with drugs like entecavir, lamivudine, tenofovir. That's HIV. That's hepatitis B. The one infection that has been able to be cured with medications from Gilead, the same makers of remdesivir, is hepatitis C. But that's very recent. We've had Hep C for over 30, 40 years. We couldn't cure it. In fact, in those days when I used to treat Hep C with pegylated interferon, only about 30% of people will get a cure. And a cure means you give the treatment for 6 months. You keep monitoring to check if the virus is gone. And unfortunately, for about 60% of the people, you have to tell them, hey, the virus really didn't go away. Even today, Hep C is not 100% cure, 99%. There'll still be that 1% of people who don't get cured. So let's fast forward to COVID-19. Take something like chickenpox. If you get chickenpox, you would get over the illness, but the virus stays in your body. And that is why when you're older or you go through a stressful situation, the virus will find its way back to the surface of your skin, and you would develop what is called shingles or herpes. Right. Take Ebola. So Ebola came and went. We thought it was gone. Well, they checked the seminal fluid and the vitreous fluid of a lot of patients. The virus was still present in semen a year after the infection was gone. So forward to COVID-19. I don't think we would find the one cure that kills the virus, because people do recover, right? Even without any treatment. So the point is, when they're forming antibodies, is that equal to immunity? At this point, just like HIV antibodies have zero conference of immunity, at this point, those who are forming antibodies, we don't even know. But we're carrying studies with a convalescent plasma, taking their blood and giving it to those who have it, with the hope that the antibodies that have formed would give them some form of protection. We're taking a gamble. We don't know. So now let's go to Madagascar. They said they found tea. I am learning this week, and I'll learn some more, that the AU has approached them. You see, African countries have done something for a long time that has kept us back from all the steps in progress. Before you prove a drug works, you need to give it to somebody who has the infection, or better still, do a randomized control trial, show that for the group of, that's what was done with remdesivir. That's why it was approved. The NIH started a trial. Give it to those who have it. Don't give it to, give placebo to another group of people and prove a few things. It could be one, the viral load decreased remarkably in those who were given the drug versus those who didn't get it. Maybe they got better quickly or something. You don't just get up and say, I found a cure. Otherwise, I'll take tomatoes or onions and say, oh, it's the cure for pneumonia. Medicine does not work like that. That's why it's a science. Right. So they need to submit their discovery to scientific rigor. It doesn't have to be a huge test, but we need to study it. So I'm going to find out this week, and I'll let you know. From my estimate, it doesn't appear they've subjected it to rigor. And that's what we've done for a long time. And we need to quickly snap out of it, because for one thing, not only is it good to do that scientifically, if it's really a cure, there's a method by which the whole world would accept it, and you would have more market for your product. You can't just come up and say, I found a cure, and not have proof of cure. And somehow, this is just very peculiar to Africans. We tend to believe things that don't have proof. Like you, Senna, right now, after this program, if you went in your kitchen, you picked tomatoes, onions, picked a few things, added oil, the weirder it looks, the better. And you did a video that said you found a cure for coronavirus. I will not be surprised. 90% of your friends will believe you. Meanwhile, you have no proof. You've not tried it on anybody. Senna said he's found a cure. Right. It is so primitive. I don't know the word to put to it.
Dr. Bertha, great point, Dr. Serwa. But let me maybe I wouldn't say, okay, let me just say this. Back before, I'll say, conventional medicine came to Africa, of course, we've had our own traditional way of, healing ourselves from all kinds of diseases and viruses, even performing, surgery in the most traditional way and all that. So would you say that, in the past, the way we have healed ourselves from all type of illness, because they have not been subjected to rigor, as you mentioned, these practices are not as effective as conventional medicine?
No, not at all. In fact, I'm supporting it. I'm rather saying that let's do things so that it can be accepted on a national or international scale.
Okay.
Music, for example, if you write a note in the music, the treble clef or whatever, somebody in Japan doesn't have to know the words. They can play the same tune because it's international.
Got it.
Right. I believe so much. Look at malaria, for example. The current treatment for malaria is artemisinin. It's from a plant. A woman studied 1,000 herbs and found this one medicine from a plant. So I strongly, and I happen to be a Christian. When you read Revelations 22 verse 2, the Bible talks about a river in heaven, and it says on both sides of the river there is a tree, the leaves whereof is given for the healing of the nations. So I'm such a strong believer in herbal medicine. But what I'm saying is, some herbal medicines have been known to cause liver failure, kidney failure. Mcgee will tell you there are some mushrooms, if you eat it, your liver would fail.
Instant death.
When I talk about scientific rigor, there are certain things. One, you discover a drug, it has to be given to animals to make sure it doesn't cause cancer, it doesn't cause death. A good example is influenza vaccine given in the 1970s. Right here in the US. The minute it was administered, people started developing Guillain-Barré syndrome. So these days, you realize that whenever you're going to get a vaccine, they ask you, have you had this? Have you had this? Sometimes it's going to harm people. You have to make sure it doesn't even harm animals. 2, you do studies, what we call phase 1. Take even 25 people, give it to them. Make sure they're not going into kidney failure, liver failure, or they're not dying right away. And then you expand it to phase 2, see that it works. I have no problem. In fact, I wish Africa, I strongly believe that the cure for COVID-19, if it exists, I suspect is going to come from a tree in Africa. What the problem I have with is preying on our intelligence and just saying, I believe. Come on, Dr. Mcgee could go to his kitchen and whip up something with whiskey and say he's got a cure.
That's what that's called.
So I just want to say that, look, we're not primitive anymore. We have education. Let's do that. And one example, I have nothing with, like, one patient from Cameroon got healed in China, and you had educated professionals believing because of one person, Africans were immune. Couldn't believe that our African scientists believe, but they did. How do you extrapolate one? And I told them, look, the fact that the guy is cured just means that Africans are susceptible. He's 21. He recovered like most
21 years old.
It's not part of it. Let's start thinking. Then the world will start taking Africa and Black people seriously.
Okay.
Madagascar has to subject its drug to approval to the right process so that it can be accepted. And I would really love it for it to be the cure. Just do it right.
In a nutshell, Africa has to combine tradition with science.
Exactly.
Excellent. Okay. So, if Dr. Mcgee, I wanted to ask you, it's time already. It's 8 p.m. and we're supposed to be ending, but we'll wrap up quickly. We'll get a few words out and then we'll call it a day. Dr. Portia Claude Maskaki will join us on Facebook. She says that there's a problem with several Facebook and Zoom events. So the technical glitch that we're experiencing is not just us. She's just letting us know that, others are going through the same thing.
That's good to know.
Right. So before I come to quickly, Dr. Serwa, now this may sound very primary, but we have a lot of people who are listening who may want to know some of these basics. The difference between a virus and a disease. A bacteria and a disease. A bacteria and a virus. I'm sorry, bacteria and
okay. So,
I see.
so in this case, let me just clarify. The name of the virus is SARS-CoV-2, capital case, uppercase SARS dash uppercase CO dash V2, with the SARS from the 2003 SARS-CoV-1, and then the disease is called COVID-19 or coronavirus infection. So the difference between a bacteria and a virus is this: a virus needs a human being to replicate because it doesn't have all the organelles. I told you how it enters a cell and
Yes.
starts commanding. Bacteria are eukaryotes, meaning they can survive on their own. They have some organelles. They are not as mature and complicated as human cells, but for the most part, if you leave Staph aureus on a plate, they will start multiplying on their own. They don't really need human beings to survive.
Okay. Okay. No.
That's
Okay.
why you can get tetanus from playing in the soil. That
Okay.
is why Ian Fleming was able to discover penicillin, because
Okay.
fungus was growing on a plate of Staph aureus cultures. And another important thing, you can see bacteria with a microscope. Viruses are so small that you need an electron microscope, a machine, to look at it. You can't see viruses by looking at a tissue sample under a normal light microscope.
Okay. All right. Thank you. And another basic question. They say that you die from a virus, you don't die with a virus. What's that supposed to mean?
I'm not sure what it means.
Okay, Dr. Mcgee, you in your line of practice, have you seen what is the patient's recovery death ratio? I don't know if that makes sense. Like, do more people leave your premises?
So just 80% of people have mild symptoms or flu-like symptoms that they get better. 15% can get severe, where they have to go to the hospital and they have lung problems. They may have pneumonia, and then about 3 to 5% can die. Right now.
Okay, but in your own experience, the people that come to your hospital, your clinic, do you see more going out healthy?
Recovered? In the ER, we don't see them when they leave, but we discharge a lot of people. We discharge a lot of people when they come in with mild symptoms. We'll do an X-ray. They don't have pneumonia. We'll check some labs. If their labs look good, if their vital signs are great, they don't have the oxygen saturations that I mentioned before is above 93%. If it's above 93%, they can go. If it's below that, we keep them. If their heart rate is above 120, if they're having chest pain because we think it may be going to the heart muscle, which causes myocarditis, we'll keep them. If they're having more symptoms like stroke-like symptoms, we keep them. But the average person is going to be sent home because when they come in, a lot of times their symptoms are not that bad. And now, like I said before, we have better techniques to treat them. So a lot of times we'll keep them and we don't have to intubate. So we just do all the basic adjunct stuff so that they can have better survival rates.
Excellent. John, in you're on the front line. So day to day, you see more people recovering from it versus the people that die from it. I think we lost John again. Okay. Dr. Serwa,
yes.
It's 6 minutes past 8 p.m. and I can be appreciative enough for the information and the information and the knowledge that you've shared with the audience, the community has been outstanding. I really appreciate it. We want to wrap up quickly, but John, can you hear me? John, okay. I think we still can't hear John. Can you hear me?
I have another conference I got to get on shortly, though. So I got to go.
So let's wrap up. Maybe your last words, Dr. Mcgee, and then we can call today. We can call it a day for now. Please go ahead, Dr. Mcgee.
So all I would say is if you can actually send out the flyer for tomorrow's meeting we're having, that'll be great. Okay. And then send to your constituents, send them the list of all the different talks. So people can choose which ones they want to be on. Okay. But most importantly, we want to have as many kids as we can to go to our Instagram. Pop Instagram is Pop on Youth Violence. It's just Pop on Youth Violence. That's our Instagram.
Pop on Youth Violence.
POP, Project Outreach Prevention, on Youth, YOUTH Violence.
Okay, Pop Instagram. Okay. Yep. Are you on any other social media platform or just that?
That's Instagram, and then we're also on Facebook, which is Pop poponviolence.org.
Okay.
No you, just poponviolence.org.
All right. Thank you so much, Dr. Micheal Mcgee, President and CEO of Premier Urgent Care in Hyde Park. I think it's the only urgent care in Hyde Park, right?
So they have other minute ones, but we're the only all Black owned comprehensive, which means we have x-rays and labs. There's some doctor's office who call themselves urgent care, but they're not doing labs on the spot and they're not doing x-rays. So that's the main difference.
All right, so hey, if you live on the south side somewhere, or even on the north side, come and check out the Premier Urgent Care in Hyde Park, run by His Excellency. I'll call you the Excellency. Run by Dr. Micheal Mcgee, who has been great and excellent tonight for our audience. We hope to have you next time to share in more knowledge on what's going on in our community, and also on the great work, regarding the great work that you're doing for the community. Thank you so much. Have a great evening.
I appreciate you guys.
You're welcome. All right. So as he takes leave of us, we would take our last words from John, your last words, and then we'll have Dr. Serwa close us. Okay.
I want to rapidly thank Dr. Mcgee and Dr. Serwa for that elaborate discussion on COVID-19, especially Dr. Serwa, what you said much about how much Africa is coming up with, all these programs. I like to be in touch with you because I like to be very, very much involved. And thank you, our able host, for this moment that we've shared. My last word here is that we should go out there with this very spirit that we carry with us, do as much as we can do for our communities, remain in touch, invent, and let us stay in touch. Someone talked about a task force for the Black people for the Black communities in Chicago. That is something I'd like to follow through. Also, I'd like to get in touch with that person, and hopefully that all other cities and states, Black people can come up with things that can impact the community. It is time that we take some of these things into our hands and not only depend on it. Still, same situation in Africa. It is time that we as Africans and even African Americans, extend hands and let us, see how much we can support these communities and to, be very helpful with some of this stuff.
All right. Thank you so much, my brother. And I'll take the last words from Dr. Serwa. How do we navigate through these hard times and, of course, the way forward?
Yeah, I would say people should keep staying informed as to new signs and symptoms, what is out there. They should take good care of themselves. If they have any symptoms, they should look in their community and see where they can get tested, drink plenty of fluids, eat well. Your immune system is not a box hiding somewhere. You're as healthy as what you're eating. And know that as Black people, you're people of honor, you're royalty. And you're here on earth for a purpose. You're Black, you're beautiful, you're strong, and we'll get through this.
Thank you so much, Dr. Serwa. Listeners, we are so grateful for your audience and your time. It's been 2 hours of constant information from this powerful lady and gentleman, and we can't thank you enough, Dr. Serwa. Once again, thank you so much. We were supposed to have you last week, but I think you saved all the information for today, so we appreciate you. And the audience love you too. Some are asking if they can contact you. So is it okay to pass on your information to anybody that reached out?
Right, and I have information on my website. It's berthaayi.com, BerthaAyi.com. I have my social media handles and everything on that website. So yeah. Okay, excellent. Okay, so that being said, listeners, once again, remember that this is the Progressive Mind Show. We'll be coming your way every Wednesday from 6 to 8 p.m. And we promise you that we'll always bring you important, pertinent conversations that would build our community. Remember, to whom much is given, much is required. This has been the Progressive Mind Show once again with your host, Alinko. And again, big thank you to all the listeners, Royal Black Jesus, Old School, Abaya, Jocelyn Nakofa, for your comments. Some of your comments I wasn't able to read because we were running through a whole bunch of information. So if I did not mention your name,
Armstrong, Ememi. I got your information, and I will try and contact Dr. Mcgee and Dr. Serwa to get approval, and so I can forward you the information that you are asking for. Once again, God bless you. We will see you next week from 6 to 8. Dr. Serwa, have a very wonderful evening. Okay, bye-bye.
Thank you.